Up until 25 years ago, treatments for familial hypercholesterolemia have largely targeted the symptoms exhibited by the patient, but none of these treatments ever went directly to the source of the problem, the DNA itself or the mRNA that is derived from it. That was until the development of nucleic acid-based therapies, a treatment composed of the same basic building blocks of DNA which target the mRNA that causes the disease, fighting fire with fire. Welcome to the genetic basis of stuff and things. Familial hypercholesterolemia, or just referred to as FH, is an autosomal codominant disease characterized by elevated low-density lipoprotein cholesterol concentrations, cutaneous and tendinous xanthomas, and early-onset cardiovascular diseases. There are hundreds of different mutations that can cause this disease and result in reduced uptake and clearance of LDL-C from the blood into the liver. They can be found on the LDL receptor itself, apolipoprotein B100, the receptor adapter protein, or proprotein convertase subtilisin kexin type 9. This complexity continues further, as mutations specific to the LDL receptor alone have been categorized into 5 classes, all of which vary when considering the severity of FH symptoms. For example, in the case of class 4 defects, the presence of the highly conserved NPXY motif means that almost all mutations to any of these residues significantly reduces internalization. However, the third position in this motif does have a greater leniency, enabling some non-synonymous conservative mutations. Class 2 defects have also been known to cause severe cases of FH, where homozygous individuals are insensitive to statin therapy, the conventional lipid-lowering drug. As a result, they require the more invasive, expensive, and not easily accessible treatment apheresis. But even where statins are a viable treatment, even at maximum doses, LDL-C is not always sufficiently lowered. Other surgical alternatives are also oftentimes too risky to be provided as an option. These numerous disadvantages of available treatments drove the pursuit to synthesize nucleic acid-based therapies such as Mipomersen, the 20 base pair antisense oligonucleotide. In 2010, Ryle and colleagues conducted a phase 3 clinical trial to assess if Mipomersen could effectively and safely lower LDL-C. It was described that Mipomersen acts by targeting and binding to mRNA that encodes for apolipoprotein B100. This then recruits ribonuclease H, which hydrolyzes the mRNA, inhibiting translation. The mRNA is then targeted for degradation, ultimately impeding the formation of LDL-C. The participants included in this study were individuals from across the globe who had been diagnosed with homozygous FH and were receiving maximal tolerated dosages of their lipid-lowering drug. Weekly subcutaneous injections were supplied, containing 200 milligrams of either Mipomersen or a placebo. At the end of a 26-week period, a significant reduction in apolipoprotein B100 and consequently circulating LDL-C was observed. These treatment effects were also found to be independent of baseline LDL-C, age, race, or sex. An immediate advantage displayed in preclinical studies and within this experiment was that Mipomersen was localized to hepatocytes, minimizing side effects on the intestine, which carries a similar but slightly different LDL-C. This was unlike the results observed from earlier rejected treatments using microsomal triglyceride transfer protein inhibitors. But this therapeutic approach was still not immune to the common downfall of most treatments: adverse side effects. Although most individuals experience mild side effects, including injection site reactions or mild influenza-like symptoms, 12% of patients experienced alanine aminotransferase concentrations that were 3 times or greater the upper limit of normal, indicating hepatocyte damage. This of course raised concerns regarding Mipomersen's safety if permanently integrated into the medical field, but nonetheless it was still revealed to be a feasible therapeutic approach to treat FH. Over the next few years, further trials similarly concluded both a significant reduction in LDL-C and elevated ALT levels, with some individuals even meeting protocol-defined stopping rules. In addition to this, elevated hepatic fat levels were also noted, indicating the potential to develop hepatic steatosis. From these understandings on Mipomersen as a therapeutic approach, further revolutionary advancements were able to be made with the more recent development of the PCSK9 siRNA, inclisiran. This more novel nucleic acid-based therapy has also been shown to significantly decrease LDL-C concentrations. This illustrates the incredible diversity that these therapeutic approaches provide, and as long as the correct trialing, refinements, and quality assurance is met, any target protein could be upregulated or downregulated. Although Mipomersen isn't the perfect RNA therapy, with adverse effects that restricted its application after the phase 3 clinical trial, it still opened the world up to the possibility of more precisely and directly targeting the cause of FH. And with the further evolution of science, this is one step closer to nucleic acid-based therapies treating not only FH, but potentially a range of other diseases.